To introduce myself, I'm happy to be here. It's a pleasure to present our paper, PURA-Related Syndrome. My name is Ralitza Gavrilova, and I'm a neurologist as well as geneticist here at Mayo Clinic. I also would like to thank the organizers for the ability to accommodate my flight delays and allowing me to present today instead of yesterday. Thank you for the flexibility. I'll go ahead and present the paper, and if there are any questions, perhaps we can discuss those at the end. I have nothing to disclose here. Okay, so let me make sure that I'm able to move. So we'll start with the case. This is a 17-year-old male who was referred to us for evaluation of delayed motor milestones, absent speech, intellectual disability, hypotonia, seizures, short stature, failure to thrive, delayed puberty, cortical blindness, and kyphoscoliosis. So the clinical history starts from birth. He was born to uncomplicated pregnancy via induced vaginal delivery at 42 weeks gestation. Birth weight was appropriate. Apgar scores were normal or near normal. But at birth, he was noted to have hypotonia and poor suck. He spent 1.5 weeks in the NICU for feeding difficulties. He was fed to a G-tube. He had a brief hypoglycemia, which resolved with frequent feedings. Based on the hypotonia, poor suck, he had an EMG, which was normal, as well as brain MRI, which was normal. During his first month of life, he was noted to have nystagmus, and ophthalmology evaluation revealed optic atrophy, hyperopia. He was prescribed glasses later on, amblyopia, and strabismus. Neurologically, at 18 months of age, he started having myoclonic and tonic seizures. At 10 years of age, he started having head drops. And at 16 years, he was given a diagnosis of Lennox-Gastaut syndrome, at which time he had between 5 and 20 seizures per day. His background EEG was also abnormal. It showed abundant generalized epileptiform discharges. There was lack of clear posterior dominant rhythm and generalized slowing. At 20 years, he was on 3 to 4 seizure medications, and that resulted in a decrease of his seizures, of his seizure frequency to 2 to 5 seizures per day. He had global developmental delays. At age 14 years, he achieved independent ambulation with the assistance of ankle-foot orthosis. At his most recent follow-up, which was approximately 20 years of age, his cognitive skills and receptive communication were at 6-month level. His expressive communication and fine motor skills were at 8-month level. His gross motor skills were at 11-month level. At that time, he had shown some neurological regression of the walking, and this was related to seizure status epilepticus, tonic status epilepticus. From an endocrinology standpoint, he had a normal growth until 7 years of age, at which time growth and weight plateaued. At that point, it was also determined that he had delayed bone age through endocrinology workup. He had, in addition, delayed puberty. There were no pubertal changes noted at 14 years of age. The diagnosis of hypogonadotropic hypogonadism was given, and testosterone injections were initiated. They stimulated puberty and growth, but not bone age. At 20 years, his testes remained pre-pubertal in size. His height and weight were well below the 3rd percentile. He was 143 centimeters and 31 kilos respectively. Based on parental height, his estimated predicted height was approximately 157 centimeters. His bone age remained delayed at 11 years and 6 months. This is the patient and the family pedigree on top. The parents were in late 30s, 40s at time of conception. And I'll just say as a geneticist that mutations occur more often at the level of the sperm based on advanced paternal age. So there was no family history of similarly affected individuals. He had 2 siblings who were healthy. And here, I'll show that he was significantly short-statured at age 17. He had some distinctive facial features, including down slanting of the palpebral fissures, downturned corners of the mouth. You may not be able to appreciate this, but he had stained enamel teeth that were widely spaced. He had mild pectus excavatum deformity in addition to kyphoscoliosis and generalized hypotonia. A muscle biopsy was done prior to our evaluation based on hypotonia, and that along with EMG were normal. Echo was normal. He had suffered from constipation from a GI perspective. Endoscopy revealed eosinophilic gastroenteritis and dietary changes were recommended. So we performed whole exome sequencing, and this is summary of the whole exome sequencing report. As you see, 1 pathogenic variant was identified, and some pharmacogenomic variants, which we will not discuss at this presentation. So this is a summary of his pathogenic variant. He was found to have a nonsense mutation in the PURA gene. Autosomal dominant mutations in this gene are associated with intellectual disability type 31. This was a heterozygous change, and this was de novo change as mother and father were negative when tested from blood. So the gene PURA encodes purine-rich element binding protein A, and the gene binds DNA preferentially to the single strand of purine-rich elements present at origins of replication. This is implicated, thus this gene is implicated in the control of DNA replication and translation. Lalani in 2014 was the first one to identify de novo heterozygous mutations in the PURA gene in 11 out of greater than 2,000 pediatric patients with various neurodevelopmental disorders. There were 4 truncating mutations, 5 missense mutations, and 2 in-frame deletions. Functional studies of the variants were not performed for that paper, but the presence of truncating mutations suggested at least partial loss of protein function as responsible for the phenotype. We also analyzed whether the mutation, which was located in exon 1, as you see here on the bottom right of the gene, whether this locus was conserved through species. And as you can see, this is a highly conserved region. We also determined if the patient's phenotype was matching the described phenotype of the syndrome. And you can see in red the features that overlapped with the classic phenotype with an onset at birth or early infancy. Myopathic facies has been described in other individuals, but as you noted, we did not find any evidence of myopathy. The patient had somewhat elongated faces. Nystagmus, strabismus were described. The patient did not clearly have respiratory insufficiency per history at birth, but he did have feeding difficulties, neonatal onset hypotonia, and severe developmental delays, poor or absent speech. At the last visit, he was communicating through an iPad, and lack of independent ambulations, epilepsy, and myoclonic jerks. We further characterized the mutation looking into other databases, including EXAC. These are disease databases that list the mutations in the gene, and no nonsense mutations were observed in EXAC. On the left bottom, you can see a schematic of the gene itself, which is located on chromosome, on the long arm of chromosome 5, as you can see here on the right bottom. The gene itself, back to the left bottom of the screen, the gene itself has three main functional domains. This red bar indicates the location of our patient's mutation. And as a result of a stop codon, we predict that there will be premature truncation of the product of this gene. On the right bottom, you can see other mutations described in other patients. And you can see that many of those mutations cluster within this first domain of the gene, but also more rare mutations were found in the other two domains of this gene. We also analyzed the literature and found that a patient with a de novo 5q31.2 microdeletion of the PURA gene itself had similar clinical features, including pubertal delay, primary amenorrhea, epileptic seizures, feeding problems, respiratory problems that eventually led to death at 26 years of age. This case, similar to ours, did not show signs of hypomyelination or other abnormalities on brain MRI. And deletions in this region have been known prior to the description that of PURA mutations, intragenic mutations associated with PURA-related phenotype. So this deletion case further confirmed the evidence of a significant role of PURA in the contributing to the main features of this syndrome. Khalili in 2003 found that PURA knockout mice appeared normal at birth, but at 2 weeks of age, they developed neurologic problems characterized by severe tremor, seizures, and they died prematurely. Regions of the hippocampus and cerebellum of these mice showed severely lower number of neurons compared with wild type littermates, and lamination of these regions was aberrant at the time of death. Immunohistochemical analysis of a marker for DNA replication revealed lack of proliferation of precursor cells in these regions. And evaluation of brain sections indicated reduced myelination and pathologic development of oligodendrocytes and astrocytes. And therefore, the author concluded that PURA has a role in developmentally timed DNA replication in specific cell types. This is a prior publication of over 10 patients with PURA phenotype. And as you can see, according to age, the oldest patient described in the literature was 15 years of age. Our patient was older at the time of presentation. I'll alert your attention to several of the features that are characteristic of this condition, and also some of the neurological features. For example, verbal skills, many of these patients remain nonverbal. As far as brain MRI abnormalities, the most common abnormality is delayed myelination. However, white matter changes, corpus callosum abnormalities, periventricular leukomalacia have also been described. As far as seizures, many patients have seizures, but I would like to alert your attention to the frequency of myoclonic type of seizures. You see that recurrently through the phenotype of these patients. The other characteristics is that many patients remain non-ambulatory. This is another paper published in 2018 of the largest cohort of PURA-related syndrome patients, 32 individuals. This publication included previously published 22 cases. And based on this review, it was noted that all patients had moderate to severe intellectual disability. Majority had hypotonia. Over 50% of patients had feeding difficulties, many requiring NG tube feedings, gastrointestinal symptoms, including constipation, as in our patient requiring treatment was frequent. Hypersomnolence was also frequent. This was reported in our patient as well. Respiratory issues, and about half of patients have also epilepsy, including Lennox-Gastaut syndrome, ophthalmologic abnormalities, endocrine abnormalities, of which the most common were hypothyroidism, as well as low sex hormones. 91% were nonverbal. Only 42% of patients achieved independent ambulation. And however, 6 cases, to my knowledge from the literature, had similar to our case, realized some regression in their motor skills or developmental skills, and most of the regression was associated with seizures. Movement disorders such as dystonia or choreiform movements were noted in about 20% of the patients, and MRI showing delayed myelination in approximately a third of those patients. These are facial features from this publication of patients. Probably, perhaps the most consistent facial features noted are elongated faces, down slanting of palpebral fissures, maybe here, as well as downturned corners of the mouth. So in conclusion, the phenotypic presentation of our case is similar to previously described patients, but he had some additional features, including severely shortened stature, delayed bone age, delayed puberty, which required testosterone treatment. At age 20, he represents one of the oldest PURA syndrome patients described, adding important natural history about puberty, growth, and development. Short stature has been described previously in PURA, but has not been as severe as observed in this patient. Delayed puberty was also previously reported in 2 individuals and is therefore a rare feature. This is the first case of delayed bone age. Cortical blindness has only been reported in 3 individuals previously. And finally, most patients have delayed walking or are non-ambulatory. However, our patient demonstrates that due to intense physical therapy, he was able to achieve independent ambulation, although late at age 14, compared to other cases reported to achieve independent ambulation between 28 months and 7 years of age. This emphasizes the importance of physical occupational speech therapy, which may be helpful for these individuals. With this, I would like to thank you, and I'm happy to respond to any questions, if any. Thank you for your